So Kaz, while we're waiting, Kaz alluded to my interest and passion for terminology. I'm going to use the term AMR. I hate the term AMR. It's a great term politically. It's got traction. Nobody understands it outside of these sort of rooms. The public don't understand AMR or antimicrobial resistance, and it's just a plea while we're waiting. It's a great opportunity for me to make this plea that we really do specify what we're talking about when we're discussing antibiotic resistance, antifungal resistance. People don't understand stewardship either, this term, this old English term for looking after things for a great family is a term which we might understand. Again, in this room, people don't really understand it. Okay, so we're off and running, hopefully. Yep, fantastic. So I do appreciate, this is a bit of an old cartoon, but I do appreciate that as a Brit coming to Australia and also living in South Africa, that it's a bit like sort of sitting here, poor Hal with his birthmark. You know, I'm open to being shot at, but I really, as I said, it's a great pleasure to be with you, and I hope that what I'm going to discuss really and been asked to discuss is a more international perspective, and particularly sitting in what would come under the umbrella of low middle income country, although I do appreciate that South Africa is an upper middle income country, but really trying to give an understanding and a voice from that perspective. So I've been through my conflicts. Yeah, what am I going to look at? You know, where should we be directing our efforts globally to mitigate this problem of antibiotic resistance? I'm going to go through some of the issues that we're really still fighting with our hands tied behind our back, this problem of antibiotic resistance. I'm going to look at 3 specific stewardship challenges that we've had to face, and then finish off with a look at maybe what's next in global governance. I am going to touch on the animal side of things when it relates to what I'm discussing, but cognizant that our next speaker is really going to bring that to the fore. So I'll try not to be too repetitive on that part. So this is what we've been working on, the premise that consumption of antibiotics drives resistance, and undoubtedly it does. This is from Herman Goosen's paper in Europe, showing this almost direct relationship between consumption and resistance. But a paper that came, actually, Peter Collingen and CDEP colleagues published this extremely interesting paper very recently in Lancet Planetary Health. And although there are issues and one can discuss the data sets that were used, what it showed that if you look rather than just in high-income countries, when you look globally, that relationship, that linear relationship between consumption and resistance is challenged. And in fact, as you can see, it isn't actually a linear relationship. In fact, there wasn't particularly a relationship when you take countries not only in the high-income sector, but in the low and middle-income country sector as well. So it challenges this understanding. And what the paper looked at is resistance and the impact against 6 different types of indicators, which within each of the indicators there were measures. So they looked at governance, which was rule of law and corruption issues, the health expenditure and GDP, education measures, climate, and this infrastructure index. And what you can see is that the biggest bang for your buck actually in altering antibiotic resistance in terms of these indicators was in infrastructure. And really the issue of clean water and proper sanitation was the main driving measure within this infrastructure index. So suggesting that infection prevention may be the most important bang for your buck if you were trying to mitigate antibiotic resistance across the board. Now, climate wasn't associated in this study, but if in another study, which again, an interesting study recently published, looking at the United States, suggesting that there is a relationship between climate change or increasing temperature and increasing resistance rates. So as you go in different parts of the United States, as you increase temperature, the resistance rate increases. So rather than saying that this paper saying that antibiotic consumption, particularly at an individual level, is not an issue? Of course it is. What it's telling us or suggesting to us is that more attention and more work needs to be centered around the question of where do, globally, and on an international scale, we get the biggest bang for our buck in intervention. And while we continue to have this sort of situation where 1 billion people are practicing open defecation, and in a world where we continue to have water insecurity for vulnerable populations, we will continue to drive a high burden of diarrheal diseases and others. And there's been a big attempt at high level to marry AMR into, or put AMR into the context of the Sustainable Development Goals. And that's a very important move because WASH, in particularly SDG 6, clean water and sanitation, is one of the important SDGs. And it's not just infection prevention through water. It is always important to be the first one in the line, okay? Because if you're the last one in the vaccine line, you've got 5 minutes to wait with everybody screaming. But vaccination is a really important prevention method. And in humans, we know the real importance of improving our PCV, pneumococcal conjugate vaccine coverage. It's globally currently at only 37%. And the amount of antibiotic days that we could save in the less than 5-year-olds and even in older people is an important reduction. And it's not just pneumococcal conjugate vaccine, of course. Influenza vaccine, this study in Ontario, where they switched from targeted to all comers for influenza vaccination, dropped prescriptions for antibiotics. So again, reducing influenza, and therefore not only the secondary bacterial infection requirement of antibiotics, but also the inappropriate prescribing of antibiotics. Vaccination in humans is important. And of course, vaccination in animals equally so, and I'm sure we'll hear more in our next talk. And the one example I want to show is the example of the incredible change in antibiotic use in the fish farming industry in Norway, which has dropped antibiotic use to almost zero with increasing production. If you want a treat, go on YouTube and type in "vaccinate the fish," and you will get this amazing video of exactly how it's done. But beware, because it's a horribly catchy tune, and you'll wake up in the middle of the night singing about vaccinating fish. So I have spared you the collective putting the video on, because I think really it would be dreadful. But vaccination also doesn't just impact on the burden of infection, it also impacts on resistance. So this study is from the NICD in South Africa and von Gottberg, showing that as the introduction of pneumococcal conjugate vaccine, first 7 and then 13, reduces the penicillin-resistant strains circulating. So it has an important impact. And in terms of vaccine production, we really need to up the game. And the WHO website shows that most of the vaccines in early stages are centered around HIV, malaria, pneumococcus. And there's relatively few, some interesting RSV and rotavirus, the rotavirus vaccine we know, some interesting vaccines for RSV. And recently there's been an injection of interest from a publication from the Wellcome Trust looking at vaccine priorities for AMR and basing it on taking the World Health Organization priority pathogens list really as the starting point, and then looking at these different markers, the impact of the vaccine, the probability of success and uptake. And each vaccine is given a scorecard. 2 is the maximum. Green light is, we're ready, almost ready to go. If you get a red 0, there are problems. And they've been able to cluster the potential vaccines, some of which are we already have pneumococcal vaccines, obviously, but there's a lot of potential work of improvement. But there are some vaccines like Shigella vaccine and vaccines for non-typhoid salmonella and some of the enteric E. coli, which are sort of good candidates to bring to market. But it also depends where you're sitting as to where you think a candidate a vaccine is important. So where I sit in Africa, the gonorrhea vaccine I see as critical, not just to treat gonorrhea and because we've got the problem of multi-drug resistant gonorrhea, but because of what it could do potentially to the HIV epidemics in Africa and how that not being able to treat gonorrhea in the future may increase HIV transmission. So I see that as important, and maybe, although it's not seen important in this publication, VRE isn't of importance supposedly. However, if you're sitting in Australia, maybe VRE vaccine becomes more important. So it's a good start to increasing the discussion, and a lot more work needs to be done in the field of vaccination for AMR. And of course, I have to acknowledge Lindsay and all others involved in Hand Hygiene Australia, really an incredibly globally impactful program, and this study most recently showing this incredible improvement in hand hygiene and the association of improvements in hand hygiene with reduction in the hospital-acquired Staph aureus bacteremia. So, of course, infection prevention also focus on hand hygiene, but I think the discussion needs to be far broader than that, and how globally, and particularly in low-middle-income countries, we really attend meaningfully now to reducing the burden of disease. So low-middle-income countries, where you put where you need your interventions will differ from perhaps from high-income countries, and particularly as the hammer blow is going to fall in terms of modelled mortality, this from the O'Neill report, suggesting that this figure of 10 million extra deaths by 2050 will fall on low-middle-income countries, low-resource settings in Africa and Asia. So maybe the idea is that we should keep calm and actually prioritise the infection prevention. So I want to move now on this issue of fighting with your hands tied behind your back, because the critical challenge for global stewardship still remains in access. And the WHO has been tasked, the tripartite has been tasked by the World Health Assembly to develop a global stewardship framework. And there is a whole set of interventions and important areas where global stewardship is described, and that goes right from R&D, which I'm not going to talk about, but all the way through this stepwise cascade towards us, where as the end users we need to use appropriately. So I'm not going to concentrate today on this side of things, although globally there are some real sticking points now about how we really push R&D, financing in particular, which need to be overcome rapidly. But access really talks to the key dual sides of the stewardship coin, not just an access to improve patient management, but also this issue of stewardship as a conservation tool for our future. And if we don't improve access to what I'm going to discuss, we're going to have a problem with impacting on the conservation side of antibiotic stewardship. So we need access to assured quality antimicrobials. As you know, antimicrobials are probably the biggest targets of falsified and substandard medicines. And really, antibiotics and antimalarials particularly are a major issue. So as opposed to here in Australia, where you can be pretty sure that the antibiotic you're giving your patient is of assured quality, in many countries, in resource-limited areas in particular, we have a major issue. So we need access to assured quality medicines. And the Access to Medicines Foundation produced this important report around stockouts and scarcity. And a lot of this lies around the development and the production of the API. And particularly, you'll remember that Piptaz had a global stockout because the single factory that had produced the API but had a fire. And also, you'll know that there's particular access issues to penicillin currently, and in PNG, I was learning last night that you're facing the same problems as we face in Africa in the treatment of syphilis. So penicillin is scarce. And when you don't have penicillin, you've got a problem, because then you start using higher-end antibiotics and driving resistance as you broaden the spectrum. Need access to national surveillance data. Most amazing, the NAPS, all the NAPS surveillance being done here is incredible. But outside of these sort of settings, and even in South Africa, we're getting there. You need national surveillance data because we need to know globally what's going on. But you need surveillance data which targets your facility. And again, although you may have that, this is a rarity. We're just starting to be able to give this sort of information in South Africa. But the Fleming Fund is putting in a lot of work to try and improve access to laboratories and improve surveillance and get to this. But for most countries, we're a long, long way off. We need access to diagnostics. Uncertainty drives inappropriate antibiotic prescribing largely. And this study from India is looking at family practitioners. And the number one issue that drove their misuse of antibiotics in their feeling was an uncertainty and a test that isn't available. But actually, even in low-income settings like Vietnam, a basic CRP can reduce antibiotic prescribing. Yet in many countries, the remuneration for diagnostic tests is not given, and therefore patients have to pay out of pocket. And if your antibiotic is a few cents and your test is a few dollars, you're not going to have the test. So patients aren't taking tests, they're being given antibiotics unnecessarily. And so even the tests that we actually do have, and even point of care, are not being able to be used. And we need access to a workforce. You've got a good workforce here. It's the human resources side of things is terribly challenging to the majority of particularly the world's most vulnerable population. We don't have access to stewards, doctors, pharmacists, nurses. And there's been, not to worry about the actual detail of this slide, but there was a recent review of resource estimates and which countries have actually published resource estimates. Is very few high income. We need standardized measures of what our workforce for stewardship would need to look like. And the other issue is that we need to ensure that we have access to prescribers of the future who understand antibiotics and stewardship. All the studies, the CAP studies in medical students, in pharmacy students, in veterinarians from around the world shows that we are not training students properly to give them the tools to be able to be confident prescribers. And even in-service training, we need to rapidly upskill. Stewardship training, to me, stewardship is a practical skill which requires training. And we have started national training centres in South Africa to give that practical bedside stewardship training to allow capacity building in hospitals that don't have stewardship. And then we have a whole follow-up system to try and improve in-service training. So at the moment, we're in a perfect balance, but we're in a bad balance. We're balanced with a lack of limited access to all the tools we need and a lack of stewardship, which is a beautiful balance, but actually where we want to be is a balance where we have universal access to appropriately prescribed antibiotics, what we're all trying to get to. So with that in mind, that we're still fighting with hands behind our back, I want to take you through three specific examples of some issues around international antibiotic stewardship. One's more global, and two in how we've tried to approach it in South Africa, as examples of some of the particular issues. Now, for those of you that are fans of Lord of the Rings, you'll recognize this picture of Gollum, who is finally has fallen into the fires of Mordor, and the One Ring, his so-called precious, is about to be destroyed. And the question I'm posing to you now is whether we are going to be destroying our precious in the fires of Mordor, because this alludes to the study of azithromycin and the potential mass rollout of azithromycin to improve child mortality. So this stems from studies in trachoma, where azithromycin is used, as you know, in mass control of trachoma. And what was found in the initial studies in Ethiopia, that not only did it improve and prevent trachoma, but it also reduced all-cause mortality in children that got the azithromycin. And from that, the study, the MORDOR study, I won't tempt you with my French here, but the acronym MORDOR stands for this, the name of the study, which basically eye macrolides for the eyes with an eye on resistance and death. And what it showed was that if you gave azithromycin 6 monthly to children from the age of 1 month on, that there was in a composite endpoint of 3 countries, Malawi, Niger, and Tanzania, that overall there was a 13% reduction in child mortality. And as you'll see, it was only in Niger where there was an 18% reduction that was really statistically significant. But the trend in both Malawi and Tanzania as well was to improvement in child survival. And what was also evident was that the greatest survival was in the children of 1 to 5 months of age, where a quarter of children survived where they wouldn't have without azithromycin. So this is incredibly impactful on child mortality. But of course, from our point of view as well, there must be caution, because we know that this mass use of azithromycin would potentially drive resistance. Now, can we afford to lose macrolides for strep pneumonia? Probably, but it will come at that cost. Can we allow azithromycin resistance and the loss of the macrolides for the treatment of Salmonella typhi? Well, this has been highlighted recently as a question to debate because of this clone that came out of Pakistan, where pan-resistant apart from the macrolides. So without azithromycin, in this sort of scenario, this is untreatable Salmonella typhi. So there is a really robust discussion. There's a lot of unanswered questions about this. What is the mechanism of action of azithromycin? Is it an effect on the microbiome? Is it an effect on the infections that it treats or may prophylax against? Why were these death rates different? The verbal autopsies, which of course only would take us so far, suggested that most of the deaths in Niger were from malaria. Should we be targeting just countries for azithromycin use, specific countries or all countries? And then what would the long-term outcome be, and due to the effect of the microbiota, all the associations with weight and with other diseases and microbiota perturbation need to be thought about. And, would it be possible to actually, like with maternal vaccination, give azithromycin to the mothers to protect the neonates in the first month? So there's a lot of unanswered questions. There's a WHO panel that is looking at a lot of these, and there'll be more on this shortly. And of course, Gates is, who was backing this study, is very keen on this, and rightly so. This is a really impactful study on child mortality, but there needs to be a lot more discussion before we introduce azithromycin across the board for children in low-resource countries. So I want to turn now to how you steward new antibiotics into resource-limited countries. There's a good example most recently of bedaquiline in the use of MDR and XDR-TB. This started as an early access program, and in South Africa we developed this as a research program. And what was important about this is it's a way of increasing capacity and equity in countries. So what we noted that was only 4 out of the 9 provinces in South Africa actually had the ability to give bedaquiline because they didn't have clinical trial sites. And so the minister rapidly upscaled that. And so there was equitable access across the country for bedaquiline. And now bedaquiline is used across South Africa, many countries, and is now a first-line treatment in the most updated WHO. But what about stewarding antibiotics into the community when you've got really big programs and diseases, not just like TB, but what about gonorrhea, which is syndromically managed, as you know, in most particularly in the resource-limited countries. And this came out, this world's worst super gonorrhea. I mean, you wonder what's coming next. It's probably because we're now in global health and planetary health, it would be the planetary's worst super gonorrhea. But I think this image is interesting because, of course, this yellow condom, if he actually had used the yellow condom, he might not have got the world's worst super gonorrhea. And I have to, any of you who are weak stomach, please put your hands in front of your eyes now, because at the same day that this came out, this image also came out. And I could not stand here as a South African not as a South African, as an adopted South African, I hope, without just pointing out that on the same day, somebody else was putting something yellow down their trousers for a completely different type of bull tampering. But I think it was, yeah, this was interesting. But we're going towards a path of untreatable gonorrhea. We've seen over the years the loss of our armamentarium, and we're in trouble now. And so GARD-P, the Global Antibiotic Research and Development Partnership, has been doing a lot of work in this area, trying to get proper target product profiles for an antibiotic for gonorrhea. Ideally, you want it as first line only for uncomplicated gonorrhea initially, but moving on to potentially complicated gonorrhea, you would hope that it would cover chlamydia trachomatis as well. You want it to be well tolerated in all circumstances, and you really want a single, one shot, because you're going to have difficulty getting people back. So there's been a lot of work in trying to develop a target product profile on this. And CARB-X, which is the early pipeline accelerator, heavily funded, which is really regenerating some of that early pipeline, has got 2 early compounds and a potential rapid diagnostic, but this is, a way off. But GARD-P has got an entire program now around STIs, and particularly around multi-drug resistant gonorrhea. And this product from Entasis, soliflodacin, is a new drug with a novel mechanism of action against the topoisomerase. And as part of this, is about to start a phase 3 multi-country trial. And the important thing about soliflodacin is it's only being developed for gonorrhea. It does have activity against others, particularly the staph, but it is only being going to be accessed for gonorrhea, which is an important move. And for access to support, GARD-P's been given us an exclusive license from Entasis with sub-licensing rights in low-middle-income countries, which is very important to ensure affordable and equitable pricing. And for in support of stewardship, as I said, it's licensed only for gonorrhea at the moment. And there's an MOU with FIND, the diagnostics accelerator, to try and produce a new diagnostic which could be used, because at the moment we're going to have to introduce it syndromically. But there's a debate about whether you should do that. There are big challenges in getting a rapid diagnostic for gonorrhea. There are multiple resistance mutations which are continuing to evolve, multiple drugs. There's the genetic resistance determinants do not equal often the MIC and treatment failures, so that relationship is in question. And there's problems with cross reaction at pharyngeal sites where a lot of the commensal Neisseria carry resistance determinants and transfer. So it's not an easy task, but it is rapidly ongoing. And the big question globally, and we should be thinking about, is how do you steward soliflodacin into the different countries? Should it be part of a syndromic? Could it be without a diagnostic test? Do you only put it into geographic areas where you know the resistance rate in the background and it's really, you have to use it? Should you wait to use it in combination to protect it, or is it time for monotherapy? And should it be just programmatic introduction, or should private practitioners be able to prescribe it? So there are quite a lot of questions around this, but it's an important, I think, international move. So that's community stewardship. Now, some antibiotics are going to steward themselves in part because of the people that we use them in, and particularly in terms of in ICUs, in serious infections where you're not going to be introducing en masse into a community, but in a very much more targeted way. And here you have ceftolozane, tazobactam, access to ceftazidime, avibactam. But in South Africa, these aren't registered. We don't have access to them. So we've been thinking about the principle of how you steward a new antibiotic for us, but in future potentially new chemical entities, into a country to try and protect them. And there's good reason to do this. I mean, even already there's therapeutic treatment failures with ceftolozane, tazobactam, which is what we're focusing on in these two reports. So just giving it to everybody is going to be, you're quickly going to lose it. And this work has really been driven in South Africa by my colleague, Adrian Brink. And we're looking at stewarding the introduction of these next generation beta-lactam, beta-lactamase inhibitors on the basis of their resistance profile, their activity against different resistance profiles. So this classification you'll all be aware of, and currently are available. PIP-TAZ, for example, really can target the ESBLs. With ceftolozane, tazobactam, although they are also available for ESBLs, what we really want to focus them on is their activity against Pseudomonas and the spice bacteria and those that carry the AMP-C, whereas ceftazidime, avibactam, once it gets there, really for the oxacillinases, and in South Africa we have a big oxa problem. It's not so much an NDM and a KPC problem, our problem's driven by oxa variants. So the idea is that, as I said, ceftolozane, tazobactam will be directed, and the important thing about this busy slide is that we are working with the national government and the regulatory body now called SAHPRA, but also with the pharmaceutical company involved to try and ensure that this drug, once it's registered, one of the conditions is that it comes with a stewardship implementation and that it comes with specific stewardship messaging on the package insert and all the documentation. And this is novel, particularly for South Africa, and I don't think this is done globally in terms of really impacting the drugs registration by stewardship interventions. And I think this is what we're going to need unless we have a really better framework of buyout of drugs, new chemical entities by an international body that then can impose stewardship provisions on it. I'm going to just turn, I think, lastly to briefly discuss One Health stewardship. We published this paper earlier this year on efforts we had with colistin. As you know, colistin resistance is now traveling globally throughout the world, the MCR1 initially from China and now other MCR2s and 3s, and really impacting. And we understood this problem in South Africa early on in our poultry, where in 2015 we started to see high MICs of E. coli to colistin in some of the surveillance. And then the occurrence of MCR1 E. coli, this study led by Jennifer Coetzee in Johannesburg. And what was particularly concerning was that a lot of these cases were from the community in urinary tract infections carrying the MCR1 who had not been into hospital settings and some who had not had antibiotics. So there's clearly transfer. Now, the legislation governing antibiotic use in South Africa is both that which is from the Department of Health, where it's prescribing only on Act 101, which is about 28% of all antimicrobial use in animals through that act. But the stock remedies, where you can just go to the depot and get a lot of antibiotics to put in feed, is the majority of animal use at the time. And the only data we had was from the early 2000s when a project was done showing that the in-feed antibiotics and in water were the majority, and those in-feed and in-water antibiotics were a lot of the ones that you will recognize very well from human use. So we did a situational analysis of what colistin we had. We had an oral powder form and we had an IV form. And we also realized that it's compounded as well by compounding veterinarian pharmacies. And there was a legal import of colistin into South Africa. One farm had floor-to-ceiling drums of 21 kilos of colistin. And when colistin's being pumped in to the animal, to food production, you're going to drive the potential for selection of resistance, and I think that's what we were probably seeing. So as a One Health Stewardship group, we, of the Ministerial Advisory Committee, we implemented immediate actions. We cancelled the registration of the oral form, we prohibited colistin use in farm feeds, and we upscaled colistin to make it much more difficult to get to and gave regulatory oversight. It was made a Section 21 drug, which means it's a named patient basis or named farm animal group basis, and you have to have there's a lot of paperwork and regulatory issues around it. And we were able to identify colistin coming in through separate API codes. But the most important intervention was a letter to all veterinarians from the South African Veterinary Council, basically saying that any conduct to the contrary of the guidelines for non-use of colistin would be regulated and regarded by the council as unprofessional conduct and potential dismissal. And overnight, pretty much colistin use in food animals was turned off. So we also have environmental impact implementation for environment. On the human side, colistin is also Section 21 regulation. We have a national prescribing dosing guideline that everybody has to follow. And through these interventions, we feel we are stewarding this antibiotic of last resort in a One Health way. And it brings us on to the last issue about food security. So the BRICS nations, Brazil, Russia, India, China, and South Africa, are driving the global requirement for animal protein. As you shift from a low socioeconomic grouping into the higher socioeconomic groupings, your diet shifts from grain-based into animal protein. And these countries are really driving the requirement for animal protein. But at the same time, climate change is diminishing our agricultural abilities, so that increase in animal protein is going to be more reliant on intensified farming. And how are we going to do this without animal growth promotion, which Professor Murphy touched on, and the head of the FAO has called for a cessation of all use for animal growth promotion, which we agree with, but how are we actually going to do this in terms of financing? The changes that need to be put in animal husbandry and all the other issues require funding. It's fine perhaps to do this in Australia, but how are low-resource countries going to do this? How is it globally going to be met? And we and others have called for a global conservation fund which takes this into account. So the financing is an issue. Antibiotic resistance, like climate change, is a tragedy of the commons. It affects us all, and if we don't act as a global unit, we are going to fail. We cannot have bystanders. It's not okay for Australia to do brilliantly and for everybody else to do badly. And that doesn't mean that Australia has to prop up everybody else, but there does have to be a high-level discussion about exactly how we're going to attack this in an international framework. And that brings this last question of whether we actually need, like climate change, a treaty or a convention to be able to deal with this. And AMR is already at the highest level. We've had a UN General Assembly high-level meeting of heads of state 2 years ago. It's recognized as the intersectoral nature. Everybody in this room, but then everybody else, the finance, the economists, all the different people that need to be involved. How do we draw this together? Sally Davis, the Chief Medical Officer of the UK, who leads the interagency coordinating group with other colleagues, there was a meeting to suggest a framework, a high-level commission towards developing a global agreement, and below the high-level commission, a body including the tripartite WHO, FAO and OIP and the Environmental Agency, making this new quadripartite sort of body actually feeding into this. Is this the right mechanism? There's a debate about this at the moment. Do we need a UN AMR? This is also the debate. So in conclusion, in summary, the reduction, to my mind, the reduction in the burden of infection prevention needs to be far higher on the global checklist of what we need to really attend to mitigate antibiotic resistance. We need to achieve universal access to appropriately prescribed antibiotics, and we need the tools to do it. And a lot of the research and the developments going on here, it's really going to help globally. And Australia is a very important player in that regard. And we need literally the sort of South African way, but I think probably the Australian way as well, suck it and see. We need to start implementing and stop talking about action and actually get on and do a lot of it. And that is being done, but there's still a little bit of paralysis by analysis. I'd like to acknowledge Adrian Brink, who I mentioned, and also my veterinary counterpart. Together we co-chair this South African antibiotic stewardship program, so Prof Moritz van Vuren, who's I've learned more from, I think, than anybody else in the field of veterinary antimicrobial resistance. The National Department of Health and colleagues in South Africa. And I leave you with an invitation to join us in Kuala Lumpur in 2020, where the International Society of Infectious Diseases, which I have the great pleasure of being president of at the moment, and Lindsay is also on the executive. We are holding our meeting in Kuala Lumpur. There's going to be a very strong AMR and IPC track. There's going to be pre-conference workshops for the area, and I really hope that you'll come, present your research, your clinical findings, and join us in this great opportunity for learning. So with that, thank you very much for your attention.